Good morning, everybody. I'm standing here on behalf of the RACE5 consortium, which is a new consortium in the Netherlands financed by the Dutch Heart Foundation. And some of the people working in this consortium are also here, like Isabel and Michiel and Monica. They are also members of this consortium, but also of the CATCH-ME consortium. And the CATCH-ME consortium tries to identify health modifiers in patients with atrial fibrillation, especially elderly patients. And both networks come together in the identification or the attempt to identify factors that are actually from the pathophysiological view associated with the progression of atrial fibrillation. Within RACE5, we identified a link between hypercoagulability and the progression of AF. As you know, there is this co-pathogenicity between atrial fibrillation on the one hand and stroke on the other hand. You can see here the CHETS-VAS score and the Hedge score determinants, and there is a huge overlap, as you know, and also some of the common gene variants associated with atrial fibrillation are also associated with stroke independently from AF. This all shows that this interaction between atrial fibrillation and stroke is more complicated than we actually thought. You have seen this slide. Karl-Georg Häusler has already shown it. It shows that also there is a temporal disconnect between subclinical AF episodes and the moment of stroke. Many episodes of atrial fibrillation in the assert trial actually occurred after the stroke and not before the stroke. So we believe that the causality between hypercoagulability and atrial fibrillation is not a one-way direction. This here is the traditional scheme. Atrial fibrillation causes hypercoagulability, and certainly in the presence of risk factors such as heart failure, hypertension, age, having had a stroke in the past, and so forth, this produces a high risk for a stroke, and those patients need to be treated. We have now indication that this causality may also work the other way around. We have demonstrated that hypercoagulability can cause atrial fibrosis by activation of fibroblasts. We have indication that hypercoagulability can lead to microvascular rarefaction because of an increased expression of angiopoietin 2, and this again may contribute to atrial fibrosis, and atrial fibrosis is a very important determinant of AF progression. And also we know that hypercoagulability is involved in the pathogenesis of atherosclerosis. Now, how could this work? We believe that ischemia is a very important event in this sequence, in this causality, in this sequence of events. You can see here the lactate production in the left atrium and in the left ventricle. Shortly after the onset of atrial fibrillation, within minutes, you see that the atrial arteriovenous lactate differences goes up, which means that the atrium starts to produce lactate while the ventricle does not. And ischemia in the myocardium is known to upregulate certain coagulation factors in myocytes. This year is taken from old work from a group in California. They looked at the coagulation activation in the interstitial space in a rabbit model of an infarct, and you see here in the zone AR at risk, this is the ischemic border zone of the infarct, there is an upregulation of tissue factor in the myocytes as compared to the normal myocardium. And this leads to the activation of coagulation factors, obviously within the interstitial space, to an extent that fibrin deposits become visible in the interstitial space. The red staining here in the ischemic border zone is von Willebrand factor, so you look at vessels here essentially, also here. This is the interstitial space, and the green staining here is fibrin. And as you can see in the interstitial space, also coagulation activity can actually take place. Now, coagulation factors can activate PAR receptors, protease-activated receptors. Those receptors are sitting on various cell types like endothelial cells, leukocytes, vascular smooth muscle cells, fibroblasts. We have identified them clearly also on myocytes. We have 4 subtypes of them, and the first 3 at least are abundantly expressed in the heart. And they are known to be involved in the pathogenesis of atherosclerosis, and we thought that it would also be possible that they have a role in the occurrence of atrial structure remodeling during atrial fibrillation. To test this hypothesis, and these experiments were done in Groningen, we exposed freshly isolated cardiac fibroblasts to coagulation factors 10A and thrombin, and we looked at various profibrotic and pro-inflammatory cell responses. We found that several cytokines such as interleukin-6, TGF-beta, MCP-1 and others were clearly upregulated by this intervention. Also, we found that alpha smooth muscle actin staining was increased. This is a marker for myofibroblast differentiation, kind of the activated forms of the fibroblasts. And also we found an increased proline incorporation as a crude measure of collagen synthesis. All this can be prevented by pre-treating the cells with dabigatran, which is a direct thrombin inhibitor. So obviously, fibroblasts really get activated by this intervention. The question is this sufficient to produce a substrate of atrial fibrillation? And this was tested in transgenic mice with a thrombomodulin gene defect. And this produces hypercoagulability in these mice. And in the mice with enhanced hypercoagulability, there was a higher inducibility of episodes of atrial fibrillation. And also once the episodes were induced, they lasted longer in the mice with hypercoagulability as compared to the wild-type mice. We then took this to our classical goat models. The animals were treated with Nadroparin, which is a low molecular weight heparin targeting primarily factor 10A, a little bit also 2A. They were treated for 4 weeks, and during those 4 weeks, the animals were also in atrial fibrillation. And we found that after 4 weeks of treatment with Nadroparin, the complexity of atrial fibrillation was lower. There was less conduction block in the Nadroparin group as compared to the control group. There was less AF-related fibrosis in the Nadroparin group, and also there was less alpha smooth muscle actin staining as a measure of myofibroblast differentiation. So obviously, blocking hypercoagulability can partly delay or prevent the structural modeling process, at least in this animal model. And the potential clinical relevance of this lies in the fact that the different anticoagulant therapies we have differ in their way how they interact with those PAR receptors. And this is shown here on this slide. So we are back to the cells, to isolated fibroblasts. You see here on the y-axis the proline incorporation, and on the x-axis you see all kind of interventions. Here you see that factor 10A in 2 different concentrations is able to increase the proline incorporation. Not surprisingly, this can be prevented by pre-treating the cells with rivaroxaban, but the important part of the slide is shown here. Here you see the effect of the decarboxylated forms of 10A, and they are analogs of the so-called PIVCAs, the proteins induced by vitamin K antagonism or absence. They are produced in patients when they receive a vitamin K antagonist. They lack the GLA domain. Those proteins cannot anchor in the membrane anymore, and then they lose a lot of their procoagulant activity, and that's what you want when you treat a patient with VKA. However, those proteins can still activate the PAR receptors and can still produce an increased collagen synthesis in the fibroblasts, obviously. So here is this again on a scheme. PAR1, so factor 10A activates 2 to 2A, prothrombin to thrombin. Thrombin activates primarily PAR1 receptors, 10A primarily PAR2 receptors, and in the presence of vitamin K antagonists, they lose a lot of their procoagulant activity, the coagulation factors, but they can still activate PAR1 and PAR2 receptors. Well, this is blocked by direct thrombin inhibitors, and certainly also by the 10A inhibitors. And that means that the NOACs may actually provide more than just protection from stroke. They may also have organ protective effect, and that is currently investigated in a number of follow-up investigations. And all this contributes to our approach to see atrial fibrillation from a pathophysiological standpoint, not that much as an arrhythmia anymore, but actually as an electrovascular coagulopathy. And here you can see a scheme that is also part of the 2016 guidelines now. You see the etiological factors associated both with stroke as well as atrial fibrillation, and this scheme tries to explain a little bit why this co-pathogenicity actually may exist. It shows that there are multiple mechanisms that actually cross the endothelium of the atrial cavity. For instance, heart failure is causing atrial stretch, of course. This produces hypocontractility of the atrium, which reduces the shear stress in the atrial wall. This upregulates pi1, and this decreases fibrinolysis, leading to hypercoagulability. But on the other hand, atrial stretch also activates the local RAS system, producing fibrosis, leading to conduction disturbances, to re-entry and AF. Or another example, coronary artery disease leads to ischemia. Ischemia, on the one hand, can produce inflammation in the atrial wall. This leads to shedding of the endothelial cells and exposure of tissue factor to the bloodstream, which means that the coagulation system is activated locally. But also, ischemia can activate, as I showed you, the interstitial coagulation system, which may activate PAR receptors, also leading to fibrosis, to conduction heterogeneities, re-entry, and atrial fibrillation. That's what I wanted to show you today. Thank you very much.